Dr. Tiller was amazingly eloquent. And one of the things that he said was, and I'm paraphrasing, I have talked to many women over the years, and they have told me about their lives and their hopes and the dreams. I have never talked to a fetus. The woman is my patient. And I think that's kind of bottom line of who are we caring for and why? And also, who are we to judge? I mean, I think it's that basic. Who are we to judge?
Hey, Beth.
Hey, Jonas.
This is Outlawed.
This is Outlawed.
Today, we're talking with Dr. Shelley Sella, who is a retired abortion provider who worked in Kansas and New Mexico, and she wrote a great book.
Her book is called Beyond Limits, Stories of Third Trimester Abortion Care,
which is coming out in paperback on May 26, 2026. We were unsure initially whether we should talk about third trimester abortion on the podcast.
I mean, I think personally when I started providing abortion care, North Carolina was under a very strict 20-week ban. So we couldn't provide care beyond that time period. And so for me, I sort of took the easy way out. And it's like, okay, I feel comfortable providing care through 20 weeks. I don't have to really think about later abortion care. But then as I started seeing more and more stories of people needing care during that time period and people who were turned away from care who maybe had severe medical complications or had just been diagnosed with fetal anomalies or, there are a whole host of reasons, and Dr. Sella talks about those. I felt strongly about it enough that I sued the state to help get access for patients who were beyond 20 weeks. And so I think Dr. Sella's stories that she shares helps people gain a greater understanding of the reasons why people seek abortion later in pregnancy. And we're really fortunate that she spent some time in the studio with us this spring.
I'm Shelley Sella. I'm a retired OBGYN, and I provided third trimester abortion care later in pregnancy for almost 20 years. So in college, I became interested in women's health, and I spent a summer interning at the Los Angeles Feminist Women's Health Center. And that was really part of the women's health movement of the 70s and 80s. It was a response to a very patriarchal, misogynist model of care. And in the clinic, it was an attempt to provide care in a different way. So it was ostensibly non-hierarchical, I do have to say ostensibly, and the lay health workers, which is what we were called, we rotated through all the jobs, and we did everything except for the abortion. So the only role of the doctor was to provide abortion care. That experience is what compelled me to go to medical school to learn how to provide abortions. I was drawn to family medicine because it's the only specialty that made sense to me, just in terms of offering a holistic approach to healthcare, that it wasn't super specialized. And then I end up being super specialized, but that's how it goes. And the reason is because when I was an intern in family medicine, I did a rotation in obstetrics. It was that experience that opened my eyes to birth. I hadn't really been exposed to it before, and I was really interested in it. And I thought that I cannot learn about it in a hospital setting, because in the hospital, the birth has to fit into the needs of the institution rather than on the birthing process itself. And I could see that, and I thought, I need to leave the hospital. So where can I learn that? The only way I can do that is through being at home births. And so I was really lucky to have an opportunity to work with home birth midwives in Santa Cruz, California, for 2 years. And then it was after that, or during that I decided, rather than go back to family medicine, to switch to OBGYN, because that just made more sense.
So the other thing that seems very different about the model that you pursued is the type of training that you would get if you were training to be a midwife, or in your case, sort of apprenticing under a midwife, versus what you were seeing as a family medicine resident and then as an OBGYN resident. Can you talk about the differences in that training approach?
So I actually had these perhaps very stereotypical ideas of home birth. I just thought of it, airy-fairy, blessing, this and that. And I wasn't a spiritual in that sense person. So it was a kind of, despite my preconceived notion of home birth that I thought, no, but this is where I will learn. It was so important for me, both as an OBGYN and later as a provider of abortion care, to be able to see the natural process unfolding, to see the role of the attendant, which wasn't to control the process. The role of the midwife I saw was to help create an atmosphere, an environment where the process could unfold, and to be there quietly, watchful, intervene only when necessary. And in the hospital, we see this all the time. Intervention because of the hospital protocols. Not everyone who identifies as a woman is capable of birth, but I will use the language of the time. But to have the woman strapped to a fetal monitor, to have constraints on, you by this number of hours, you need to have progressed a certain number of centimeters. It felt very controlling. And I think that was the part that I saw from the beginning, like how the person was being controlled. And so who was doing the controlling? It was the institution, really. I mean, when I think of residency, I think of a military model of training. It's very regimented and it's very hierarchical. And the person 1 year above you is the one who's training you, who's above you, but then there's the second year, then there's the third year, then there's the chief. And then the chief, I mean, what kind of language is that? And then there's the attending. As opposed to the training that I had with midwives, I worked with, in the beginning, one midwife in particular, and I can't remember exactly how many months I spent, but I was just by her side, and I wasn't doing much of anything, maybe turning on the stove to boil water so that there'd be warm compresses. Mostly, though, I was there to observe, and I spent a lot of time watching and, of course, supporting the person, but not being the primary midwife. So it's a lot of paying attention, close attention, and then talking about it later. And gradually, I was more active.
I think it's really hard for physicians to give up control. I've seen it change over time, though, I would say in the last 2 to 3 decades, like how the process and how patients were talked about 20 years ago is very different than it is today. And I think patients, the balance of control is shifting, I think.
That's good. Yeah. But I trained 40 years ago. So that was really a long time ago.
Right. And there were mostly men in OBGYN at that point.
I thought, and I think maybe a lot of other people think, when more women entered the field, it will change dramatically. And now most OBGYNs are women. I don't know that the field has changed all that dramatically. I have friends who are OBGYN residents. It's still the same thing. Really, it's control issues. So I'm happy to hear that you think it's changed a little. But I don't know that fundamentally it has shifted.
There's at least recognition of respecting the agency of patients and thinking about it. I mean, I did my residency training in Oregon. I mean, there's a very different environment in Oregon, I feel like, on our labor floor than there is in North Carolina on the labor floors that I've been on in terms of what patients desire and then how you approach the patients in relation to what they do and how you interpret the evidence to, if you think about like preventing the first C-section, whether is it an 18-hour deadline when you do the C-section, or is it no earlier than 18 hours that you would do the C-section? And that interpretation varies quite a bit.
Well, even that there's a number, which gets to gestational limits, actually. There's an idea that there needs to be a limit, that there's a number, rather than looking at the individual person and their circumstance. I hadn't thought of that before, but there definitely is a connection. Have you heard about the coerced C-section? I think
in
Georgia?
Where they got the woman basically in front of a judge on Zoom.
While she's in labor. Yeah.
Yeah. So she'd had, I think, 2 or 3 prior C-sections, and basically I can totally see how this played out, right? Like, like the nurses and the doctors are talking at the nurses' station about like, can you believe so-and-so is doing whatever? And then it ends up down this path.
Yeah. It ends up being a legal issue, and she was forced to have a C-section.
I mean, that's assault.
Yeah.
Right?
And this is a Black woman who is a doula.
Yeah.
So
yeah,
she knew what she wanted, and she didn't get it.
Yeah.
So I met Dr. Tiller, who was at that point one of 2 abortion providers in the entire country providing third trimester abortions. We were at the National Abortion Federation meeting, and at that point I had changed from being an OBGYN generalist, and I was providing abortions locally in the Bay Area. And I was at this meeting, and he was at the meeting, and he had a booth. He was showing a video of a delivery. His protocol was induction delivery of a stillborn, and he was saying the 4 axioms of the practice. 1, the woman's body is smarter than the doctor. Time, patience, and the baby will come. Respect the woman's rhythm. And if you forget the second and third, remember the first, the woman's body is smarter than the doctor. And I piped up and I said, that's midwifery. And within 5 minutes, he had offered me a job. So there was that connection from the very beginning. And when I went to visit his clinic, there was that same kind of careful attention to the person's physical well-being, but also their emotional and spiritual well-being. There was this whole different flavor than a hospital experience. And so I worked with him for 7 years until he was assassinated in church in 2009.
So one of the interesting things, as we were talking with Dr. Sella, is this, idea of kind of this training lineage. Like she and a handful of people were trained by Dr. George Tiller, and they've gone on to train other people. It made me think about the people who had trained me and kind of where they had received their training. But for this very specific kind of care, not a ton of people in the U.S. that are providing this care.
Yeah, and I think what you're mentioning is both the specific type of care in terms of later abortion care, but also the sort of philosophy that Dr. Tiller brought to how he approached patients, how he treated patients, the respect. And interestingly, Dr. Sella called it, who had trained with midwives, this midwifery model. In the book, she writes really compellingly about how Dr. Tiller is a family medicine physician who was practicing in a small town where his father had practiced, and his patients came to him requesting that he help them and help them get abortions. And Dr. Tiller was unaware that his father had provided that service. Yeah. But eventually, once he thought deeply about it and heard this request from patients, he felt morally compelled to start providing abortion care.
No, I think it's a really beautiful story in how he came to this work. Many people are probably aware that Dr. Tiller died on May 31st in 2009, almost 17 years ago now. He was murdered in his church on a Sunday morning for the care that he provided. And he was the victim of multiple acts of violence.
That was the second assassination attempt, right?
Yeah. And what's really striking about that is when you read quotes from his patients or when you read quotes of Dr. Tiller, I mean, he's kind of this person that just exudes kindness. If only people could have some understanding of his philosophy, who he was as a person, how he cared for people. He says, the women in my father's practice for whom he did abortions educated me and taught me that abortion is about women's hopes, dreams, potential, and the rest of their lives. Abortion is a matter of survival for women. It is my fundamental philosophy that patients are emotionally, mentally, morally, spiritually, and physically competent to struggle with complex health issues and come to decisions that are appropriate for them.
The anniversary of his assassination also comes against the backdrop of new actions by the federal government. The Trump administration is saying that the Biden administration misused the FACE Act to bring suits and argue for longer sentences against people who had perpetrated anti-abortion violence or violated the FACE Act.
Many of those folks were pardoned who had been accused of physically or verbally assaulting people.
Now, the FACE Act is legislation from 1994, essentially to prevent violence against abortion clinics, to protect people who are seeking reproductive health care in the clinics that provide it from violence. So unfortunately, this comes in the context of what feels like, as a provider, a risk of increased or ongoing violence against abortion clinics.
One of my colleagues from Kansas, where we worked with Dr. Tiller, and I were invited to start a third trimester abortion practice in a clinic that was already providing first and second trimester abortions. Southwestern Women's Options Clinic. And there we developed, I call it a midwifery. When we got to Albuquerque, we developed further, I would say, a midwifery model of care. And we always had licensed midwives on staff. And so that approach of what I told you of respecting the process, which was also Dr. Tiller's approach. He was very process-oriented. Respecting the process, respecting the person, trusting the process was a deep part of the care that we gave. Training that I had with Dr. Tiller followed the same model, which is so interesting to me because in a way he was a midwife at heart, but it wasn't that he practiced midwifery. Well, that's not true. He did practice midwifery. But I don't think he realized that. But to me, it felt like it. Although he did tell me that his sister had a home birth, and I think he was horrified by it. But then we spent more time talking about home birth, and I think maybe he changed.
But he's kind of like he's not the obvious midwife, right? Like he was former military, like he was always...
Yeah, he was such an interesting character because on the one hand, he was formal, like on the first day of the process is when we would meet people. He always dressed up in a suit. He was very kind of aware of how he presented, how he spoke, but he was very soft-hearted. He wasn't in a rush. He was patient. The way he trained me was how I was trained by midwives. Because in the beginning, so the clinic offered all trimester care. And relatively early on, I started offering first trimester abortions with him, step by step, gradually increasing gestational age. But in terms of the third trimester practice, I spent a lot of time just observing. And we spent a lot of time talking about the care. And we spent a lot of time with the patient. Abortion is stigmatized in general in the United States. But the further along you are in your gestation and the pregnancy, the more stigmatized it is. So Dr. Tiller divided patients into two groups, the fetal indication patients, those with either a lethal anomaly or condition that would lead to severe medical problems after birth, and maternal indication patients. Now, when we think of maternal indications, we tend to think, someone with a very severe medical problem, severe hypertension, severe asthma, severe heart disease, that if they continue the pregnancy, it would be life-threatening to them. And those people certainly deserve an abortion, but they were too sick to be able to care for in an outpatient setting. Those people needed a hospital, which was a problem in and of itself because there are not too many hospitals that will be willing to do abortions later in pregnancy. So what we meant by maternal indications are those people with very difficult life circumstances. And that group in particular was a group that often had not told anyone that they were pregnant and had hidden it for months and months. So for them to sit in a room with others who had done the same, who knew exactly what they were going through, was so powerful. And for the fetal indications too, because often they felt like, this condition that my baby has, no one else has it. No one knows what I'm going through. Everyone in my world knows I'm pregnant. And now I'm having an abortion. How do I handle that? What's it like? It was so powerful for them and for us, the providers who were in the room facilitating the group, to witness the support that they gave each other. I think it's really part of care. Beverly, you talked about prenatal care that sometimes is done in a group setting and how helpful that can be.
Yeah, I mean, I think times when people are vulnerable and maybe can't share openly, those are great times for like that centering midwifery model of care. Centering really came out of midwifery practice.
Yeah, I mean, I think to sit in a room where you know that no one will judge you is very powerful.
It also acknowledges that the patients have a special expertise, right? Mm-hmm. That we haven't all gone through what they're going through. And so the wisdom of someone else who is going through it is...
Yeah, which reminds me actually, and I think, I don't know if many abortion clinics have it, but I know of at least several. And we had this in Albuquerque in the recovery room. We had notebooks for the patients. And so that was on each recliner had a little notebook, and we encouraged people to write in it. And that was support also because it was both. It was for the patient themselves to write about what they were going through, and then they often supported whoever was going to read it. Like sometimes it would say something like, well, to the next person who reads this, you know that you're doing the right thing. God is with you. You go, girl. I mean, just lots of different expressions of support. And I think that's powerful too. So there was, just as what I said with working with midwives, there was that whole observation time. And then gradually I became more and more involved in the more active part of the care until at some point he even went on vacation. And it's not as if I was there alone. I mean, the staff was incredible. He had a right-hand woman, Kathy Revis, who was, to me, she was a midwife, just the way she cared for people. And we worked closely together. So we're never alone, really, as providers. We're always working with staff who are really dedicated to the work. So that's how I was trained. And that's how Dr. Susan Robinson was trained. She was the second woman in the U.S. to openly provide abortion care in the United States, third trimester abortion care. So that when we came to Albuquerque, New Mexico, at Southwestern Women's Options, that model was what we followed. And from the beginning, we were intent on training the next person. So we did. We trained Dr. Carmen Landau in the exact same way. And I think of it as an apprenticeship, really. It wasn't rushed. It took a long time. Almost as soon as Susan Robinson retired, it was like, okay, so now it's time for the two of us, for Carmen and I, to train someone. And so then we started training someone. Again, in that very slow, deliberate way, an apprenticeship. That was fabulous. I mean, I think it's a wonderful model. I know in hospitals it's impossible to have that kind of training, but it was invaluable.
I think trainees are also programmed to like they want to do something with their hands right away, and there's sometimes a lack of acknowledgement of just the watching and seeing relationships and how those develop between the clinician and the patient, and there's so many other parts of it that I would say are probably more important to the patient than your technical skill.
Yeah, and although the technical skills
it's
are
very
also
important.
super important. And actually, the more experienced I got, the more interested I became in watching other people. You can learn so much, and you can pick up just little things, little nuances that in the beginning, when you're first starting, you don't even notice.
So our clinic nurse, Sally, who now does our nurse triage role, was for many years also the main bedside provider for our abortion clinic. And, about 2 years in, she sort of gently said to me that I was doing procedures too fast. And I had been, right, like my metric for myself was I can do this faster than anybody else. Right. And like that was sort of the quality metric under which I was judging myself. I was like, if we can just do this as quickly as possible, that's the best, right, for the patient. I don't even think at the time I thought that she was right. But you have to be open. You have to sort of think about it to be able to take that in, right, to take that as feedback and understand, oh, well, there are other ways that other people may be doing it better.
And also, I mean, the goal is not to do it as quickly as possible. The goal is to do it as well as possible. Right. And just in terms of the training with him, in terms of just the technical part of first trimester through the second trimester, it was very deliberate. And the way that we trained was step by step. So I provided up to 12 weeks, then 13 to 14, then 15, then 16. It was very gradual. It wasn't haphazard. And before that, in residency, it was completely haphazard. Oh, someone comes in 18 weeks. Oh, yeah, okay, you can do the abortion. But it's very helpful to be systematic about this. Doesn't always happen in residency, though, right?
No.
I see your face.
No, I totally agree.
Yeah. Like, that's not how you learn, I mean, in residency, because you don't have the time.
So I want to talk about exceptions, and I think you're the best person to get into the weeds about this. So Jonas and I wrote this perspective piece that was in the New England Journal about why doctors should not negotiate with legislators about exceptions, that it's unethical for us to negotiate. And I think some people take this like, well, it's a harm reduction approach, but I really don't think we're going to get there with incrementalism on this. And I think the way that you describe your practice in the book is that you were lifted of having to decide who gets compassion. And I think of exceptions as these like little spheres of compassion. Like, okay, we have this exception for rape and incest. Okay, you can fall into that little definition. We can care for you. We can give you compassion. But if you are in a relationship that is plagued with violence, you fall outside of that sphere and we can't be compassionate for you. Yet you were able to transcend all of that and just be compassionate. And I think we need to be more like that. So I don't know if you want to talk about kind of exceptions and kind of how people fell out of exceptions, but then fell into your care.
Well, the thing is, even with these exceptions, people who were victims of rape and incest often couldn't access an abortion. So that's kind of, can I say bullshit?
Yes.
Okay. I said it. There's so many barriers to getting care, even if you fall within the exception. So the whole premise, I think the premise is to help people feel good. Like, oh, we don't ban it completely because look, it's okay in the case of rape and incest. I believe this strongly. I don't believe in a hierarchy of desperation. I took care of a lot of people over a lot of years. And the situations, the circumstances that people were in sometimes were just jaw-dropping, so difficult. And they didn't fall into the rape and incest exception. Those people aren't deserving of an abortion. Deserving. For one thing, even just the premise of deserve, I think anyone who feels that this is what they need is deserving. We are all deserving of good care, compassionate and competent care. And there should not be these restrictions. And putting them, for one thing, there are only two. So then there's this idea, we should have more exceptions. Forget it. We don't need exceptions. It should be available to all who need it.
So in our medical record, you put in like a standardized template and then fill in the template. And when the template said reason for abortion, what I felt like was that's part of the checklist that the residents are doing, right? So they're going to go in and they're going to say, why are you having that? Yeah. You're good at supporting people and you're good at talking to people. So are you, Beth? Right?
Thanks.
And so, but that's not the skill we teach, right? It goes back to that's a much harder skill and a much more time-consuming skill to learn. And so then if you make it your default on the checklist, you make it your default on the part of that counseling discussion, this is something I have to document before I can do this abortion. It suggests that, I don't know, to me it pushed it the other way. It pushed it like we're some sort of gatekeeper that we can't provide the abortion unless we have this reason documented.
Yeah, well, that is so interesting to hear that. Like it's part of the checklist. Reason for. And so then you're coming at it like, okay, I just have to fill out this form,
right.
That's also bullshit.
Yes.
That's not about caring for patients. I mean, in that situation, I would almost suggest reason patient requested for everyone, like just kind of like a blank, everyone, obviously they're there, they want an abortion, like so that it's not this kind of, I need to find out. Because that to me is very intrusive.
I feel like not asking sort of fits into this stereotype that abortion providers are not caring, that they don't want to like hear stories. And if we don't try to hear our patients' perspectives, I feel like that's like not how I was like brought up to talk to people. I don't know. Like I think it's important to ask or to talk about it if they want to talk about it, and don't talk about it if they don't want to talk about it.
And how do you?
Yeah, I agree. But what I do is when I, enter the room, I meet the patient and I say, some people want to talk about why they're here and other people don't. And I'm happy to support you if that's a conversation you want to have with me. And if you don't, that's okay too. I think the hard thing, going back to the exceptions, is that we are providing care for a lot of people who are able to access care because they meet one of our check boxes, one of our exceptions. And then we really do, from a legal standpoint, our...
have to hyper document.
Right. We need to document for us, for their insurance, for all those reasons. And that changes the context of the care too.
But that speaks to... It doesn't speak to what your beliefs, your philosophical beliefs about exceptions. It's more, this is the reality. And I recognize that. I kind of have this very idealistic view of how care should be offered and about gestational limits, which I don't believe in. But I recognize that there are a lot of restrictions, and there are states where it's banned and there are states where it's heavily restricted, and we are dealing with the reality. Yes, just because you're living with these exceptions and that's how you provide care, it doesn't mean that you can't dream of something better and that that's your overarching principle that will guide you, right? You're just, you're dealing with the kind of, okay, right now I have this is what's going on. But it shouldn't stop your brain from thinking, from dreaming of something better.
I think it does stop people from thinking outside of that, what care is worthy. Like you get conditioned to think like, okay, only this care is worthy. And like if the laws do change, will I be able to change my frame on that?
Yeah, they should read my book.
I think they should absolutely read your book.
Well, yeah, they should absolutely read your book. And I think that people have been quiet about third trimester abortion, right? And even within the community of abortion providers, there's some urge to maybe not acknowledge that it exists or talk about only the rarity or talk about the sort of extreme circumstances or and it seems like it feels dangerous to have a book like this, right, where that is honest about the care. I think that no one could read it without learning a lot about the patient's circumstances and sort of coming around to it. If you were advising a candidate in a presidential debate about what they should say, I mean, you just said you don't believe in gestational limits. And I've heard that asked in a debate, do you think that there is any line? How would you advise them to answer that question? How should we think about that question? How should we answer it?
I think one thing is important not to be defensive and rather be offensive. I think the important thing is the patient, the pregnant patient, and their lives and their circumstances. And if they need an abortion, they should have access to abortion care that is competent and compassionate at all gestations. I mean, I think that this focus on a limit is obviously very limiting. It's narrow thinking, and it doesn't deal with the reality of people's lives. People's lives don't fit into a certain gestational limit. And I saw that time and time again, not necessarily, especially with fetal indications, but think about a fetal indication patient, a pretty typical one, who gets a diagnosis at 20 weeks, and she lives in a state which has a 20-week limit, but she just got the diagnosis and it wasn't quite clear, and so she wants to go get more testing. Or maybe the condition is really manageable at this point, but she does get more testing, but weeks go by, days go by, weeks go by, and by the time there's a final diagnosis, she's past the gestational limit because pregnancy doesn't follow gestational limits in whatever state you live in. Pregnancy continues. And to get more information, it takes time. And so to limit someone's ability even to get more information because the limit is 20 weeks, 12 weeks, whatever it is a disservice, which doesn't even speak to all the restrictions and bans that people are dealing with these days and how difficult it is to get access to care and having to leave your state and having to raise money for the care and for getting to the care. That all leads to delays. And so people are coming in later and later.
I mean, so many of the stories that you talk about are, really highlight how different states have such unfair systems for care, whether it be, access to insurance or access to prenatal care or access to fetal diagnostic care or, support for kids once they're in the world, and it is so much more complicated than people just wanting to draw a line and say, okay, this is our line.
Yeah. Well, life does not follow that line. And I think it's just also important to stress that the United States does not have universal health care. And there are so many barriers to accessing health care for people.
I did fellowship in family planning, and I didn't have exposure to third trimester abortion care, and very few of the people who trained in my fellowship cohort across the country did because it's rare. There's few providers, and I think that unfamiliarity is also something that creates fear and uncertainty about what the care looks like, what you're doing, how to do it. How do you help people be comfortable with it? How do you help people train in it?
Well, I mean, there's a lot of levels to your question, because how to help people be comfortable, there's the general public, and that's speaking out and talking about it publicly. There's medical students, and I'm spending a lot of time talking to medical students, which I'm loving because they're at the beginning of their career. So to expose them to abortion care later in pregnancy, to all trimester abortions from the beginning, is a way, I think, to address that issue, that fear, that they can actually have conversations with someone who's done this work and is very comfortable talking about it. And then later in residency fellowships, at our clinic in New Mexico, we always had residents and fellows come. And I think word spreads. Like a fellow would come from whatever place, and then they'd go talk to the other residents and fellows. Oh, wow, the clinic there is so amazing. And then they, it just kind of gradually spreads. And I think that's helpful. Also, just speaking at conferences. I think the more open we can be, those of us who provide that care, the better. And I definitely see a shift, because when I first started doing this work, so it was me, Dr. Tiller, and Dr. Hearn in Colorado. And certainly within the abortion provider community, I got support. But it was pretty muted when I think about it now. But that has shifted so much. I mean, the younger providers are really interested in this work and want to do. It's like, oh, I want to be like you. I want to do this work. I never used to hear that. And I think partly it's because, especially Dr. Robinson and I we're open, and then Dr. Landau, just very open about what we did and speaking at conferences and being open to people coming to visit us. So I think the more that we can talk about it, I think the better.
If we're afraid of talking about it, it would infer that we have something to hide. But I don't think there's anything to hide at all. I think there's so much beauty in the care that you've provided to people, and you've given people their lives back and alleviated suffering. And that's why we went into this profession, is to alleviate suffering.
I think that's the baseline, really.
It should be.
Yeah. I just want to say, Dr. Tiller had a different attitude. He didn't speak out very much. He felt like the work spoke for itself and that his focus was just on the patients. But after he was killed, Dr. Robinson and I just had a different view. It's like, that didn't serve him. He was quiet and he was still assassinated.
Opinions expressed on this podcast are our own. Philanthropy keeps this podcast ad-free. To donate, you can find a link in the show notes.
This podcast is executive produced by us, Dr. Bev Gray, Dr. Jonas Swartz, and Stevie Manning.
Thanks to Nick Thorburn, Patrick Ford, and Maker for our score. Extra special thanks to Dr. Shelley Sella for the time she spent with us in the studio, and
just for being an amazing human being.
And people don't usually thank you for that, but that's a good thing.
You should be.
Yeah, it's a net good.
For being a good person. Her book comes out in paperback May 26th, so check it out. Beyond Limits, Stories of Third Trimester Abortion Care.